to the extensive session on infertility. Now we will go to obstetrics, that is placenta accreta, which is a challenge for all the obstetricians to diagnose and manage. So I'll go through diagnosis of placenta accreta. So my presentation will be in the following headings. So first we'll see how the normal placenta looks. So normally placenta is uniformly echogenic structure along the uterine wall, and it should be homogeneous in appearance. There should be a deep hypoechoic band which separates it from the myometrium, which is called retroplacental zone. And this retroplacental zone is vital to rule out implantation disorders. So placenta accreta is not a clinical diagnosis, it is a clinico-pathological diagnosis. We can confirm only after pathology examination of the placenta that we had an accreta. So placenta accreta spectrum is an abnormal trophoblast invasion into the myometrium and sometimes beyond serosa. So we have types like accreta, increta and percreta depending on the depth of invasion. So FIGO classification, grade 1, they call it as creta, placenta creta, which means it touches the myometrium but doesn't invade the myometrium. Grade 2 is invasive placenta which enters into the myometrium, and percreta is, depending again, if it is limited to the serosa, it is 3A. If there is a bladder invasion, it is 3B. And invasion to the other pelvic tissues or organs, it is 3C. So what is the pathogenesis of placenta accreta? Because during scar formation, there will be uterine remodeling that leads to failure of normal decidualization and loss of subdecidual myometrial layers. So in the scar tissue, the villi will be directly anchoring to the myometrium or perimetrium. So these extravillous trophoblasts also, they transform into high volume and high velocity blood flow vessels. So vascularity will be high. So that leads to formation of the placental lacunae and fibrinoid deposition at the uteroplacental interface. So because there is no proper formation of Nitabux membrane, there will be detachment problems. So main risk factor for placenta accreta is you should have a placenta previa with previous caesarean section. So as the number of caesarean sections increases, the chances of accreta will be more. So with more than 3 previous caesareans and placenta previa, the chance of occurrence of accreta is 70%. So other risk factors other than previous caesarean section are any history of uterine surgery, like myomectomy if we are entering into the uterine cavity, and hysteroscopic removal of uterine adhesions, cornual resection of ectopic pregnancy, any DNCs and endometrial ablations, pelvic irradiation, postpartum endometritis, and there are studies that transfer of cryopreserved embryos also leads to placenta accreta. So what is the significance of placenta accreta spectrum? There is increased maternal morbidity 2 to 7% and mortality is 7 to 10%. And we know the complications like there will be severe maternal hemorrhage, need for blood transfusion, peripartum hysterectomy, damage to adjacent organs and postoperative complications and infections. So what is important? We need to diagnose antenatally and manage accordingly. So earlier prenatal identification is best through ultrasound, and they have come to the conclusion that the sensitivity of ultrasound is around 90% and specificity 96% in detection of placenta previa. So in the first trimester, that is what we can see is caesarean scar pregnancy, because caesarean scar pregnancy and placenta accreta share common histology. So first trimester is the caesarean scar pregnancy, and in the second and third trimester it leads into abnormally invasive placenta. And what is the incidence of caesarean scar pregnancy? It is 1 in 800 to 2500. So when we see a caesarean scar pregnancy in the first trimester, and if the woman want to continue the pregnancy, we should guard her about the risk of developing adherent placenta. So what is the criteria for cesarean scar pregnancy in the first trimester? So the gestational sac will be in the lower uterine segment, and the sac should be in the cesarean scar area, and you should see multiple vascular irregular spaces. So this is a crossover sign which tells us which cesarean scar pregnancy develops into placenta accreta. So this is the sagittal section of the uterus. We need to draw one line from the fundus to the internal os of the cervix and a perpendicular line from this midline to the scar area. If our gestational sac is implanted in the figure like a B, completely upper to the sagittal line, then the chance of accreta will be more than in cos 2 minus. So they have told the risk of placenta percreta was significantly higher in pregnancies with cos 1 than in pregnancies with cos 2 and women with cos minus 2. So if we see a gestational sac implanted completely in the uterine scar, we need to guard her that she has chance of developing accreta if she continues the pregnancy. So in the second and third trimester, there are standard ultrasound descriptors to define abnormally invasive placenta. These criteria improve the reproducibility, increase diagnostic capabilities, and it facilitates international collaboration. So we need to check in the second trimester TIFA scan all these 11 features to justify placenta accreta. So 2D grayscale we should see. We'll go in detail each and every one. In the 2D, first is the loss of clear zone. So normally, you will have a retroplacental hypoechoic piece. If that is lost, then we may suspect it accreta. So here you can see the hypoechoic plane, but here it's not there. And next is the lacuna. What are lacuna? They are hypoechoic vascular spaces, large and irregular. Feinberg has graded into 3 types. 0 is no lacuna, 1 is 1 to 3, 2 is 4 to 6, and 3 is 6 or more large irregular lacunae. If you have Feinberg grade 3, the sensitivity is 87%. Sorry, 100%, 87% for grade 1. So next comes to the bladder wall interruption. So you need to see there is a smooth line of bladder wall. If there is any interruptions, then we need to suspect accreta. And then coming the myometrial thinning. So normally myometrium will be measured at the level of the inferior uterine segment between the bladder wall and retroplacental vessels. Visualized with use of color Doppler. Mean myometrial thickness was 4 mm. If it is less than 1 mm or undetectable, then we consider it as a myometrial thinning. Okay. Placental bulge. So here you can see clear line, and here there is a bulge in the placenta. And focal exophytic mass. So in one area there is interruption in the bladder wall. It indicates focal exophytic mass. So color Doppler we see 4 features like utrovesical hypervascularity, subplacental hypervascularity, bridging vessels, and placenta lacunar feeding vessels. So normally it will be in like B. So when you put color Doppler, it should be like that. If we see increased vascularity, then we need to suspect. This is subplacental hypervascularity. And this is a feeder vessel for the placenta lacuna. And that is bridging vessels we can see in the placento-uteroplacental interface. So this is 3D power Doppler where we can see intraplacental hypervascularity. So we need not see all these when we do a scan. But if these, so they have given a criteria. So number of previous cesarean deliveries. If it is more than 2, the score comes 2. Lacuna dimension, if it is more than 2 centimeters, then 2. So, and number of lacuna, less than 2 or greater than 2. and whether there is obliteration of uteroplacental demarcation. Placenta is anterior or posterior. Anterior or placenta previa. And Doppler assessment, how is the blood flow in the placenta lacuna, and hypervascularity of placenta, bladder, and or uteroplacental interface. So each criteria is given 1-2 points, and based on that we category. If the points are 8 to 12, then there is high probability for morbidly adherent placenta. So this is a proforma where you need to tick all and see whether they are coming into high probability, intermediate probability, and low probability. So now again a study has been done in 2023 where they have taken the opinion of all the experts, and it is given in 2023 journal Modified Delphi Study. According to this, they have reached to a consensus that prior history of one cesarean delivery, myomectomy, or previous history of placenta accreta spectrum, we should do a detailed TIFA to rule out placenta accreta. And they have come to the conclusion of out of 11, 7 are the main signs. So you should see whether there is clear zone or not, myometrial thinning, bladder wall interruption, placental bulge, uterovesical hypervascularity, placenta lacunae, and bridging vessels. And they have come with the new thing, that is intracervical lakes is a new ultrasound sign to be reported in patients with high risk for placenta accreta spectrum. So learning points from this Delphi study, we should do a transvaginal ultrasound in the mid-trimester scan, that is in the TIFA scan, to precise the position of the placenta and the anatomy of cervix. Anterior placenta previa or placenta previa with cervical involvement increases the probability of placenta accreta spectrum at birth. Loss of clear zone, bladder wall interruption, and the presence of placenta lacunae and placenta previa involving the cervix can predict surgical outcomes. So MRI mainly done for posterior placenta and obese mothers to assess the invasion of adjacent structures while planning for surgery. So this staging based on ultrasound they have given, and they have compared it with the outcome. So past 0 is you will have a placenta previa with no ultrasound signs of invasion, or if you see placenta lacunae but no evidence of abnormal uterus bladder interface, then it comes past 0. 1 is presence of at least 2 of the placenta lacunae, loss of clear zone, and bladder wall interruption. 2 is +1 plus uterovesical hypervascularity. Past 3 is increased vascularity in the inferior part of the lower uterine segment extending into parametrium. So as the ultrasound severity increases, the blood loss, operation time, length of hospital stay, surgical complications will increase. So management part will be discussed by Deepa ma'am. And final conclusion, so what is important is we need to see in the ultrasound placenta. Placenta evaluation is integral and vital part during anomaly scan. Important to exclude placenta accreta in high-risk cases. We should go in a systematic and methodical assessment. And in TIFA scan, compulsory we should do a transvaginal ultrasound to confirm the position of placenta and the anatomy of cervix. Prenatal diagnosis plays a potential role to reduce maternal, fetal, and neonatal mortality and morbidity. Now I invite Deepa ma'am for management of placenta previa, accreta.